Surgery, PANS. On behalf of PANS, I welcome you all to the second lecture of Operative Neurosurgery being held by the PANS. During the talk of our speaker, all attendees will be muted to enable the speaker to present without any interruption. Questions can be submitted in the chat box and will be answered when the presentation has finished, whatever. Attendees can also raise their hand for the questions. We will unmute them to speak. This session will be recorded and the link will be shared on the PAN's website. The speaker will take about 45 minutes for the topic presentation, and after that, there will be an open discussion between our esteemed speaker and the attendees. The topic for today's session is microsurgical anatomy of the central core of the brain, and our amazing speaker for today is Dr. Eduardo Ribas, who is also the director of this course. Dr. Eduardo Ribas completed his neurosurgical training from University of Sao Paulo and did his postdoctoral internships and fellowship at University of Sao Paulo, University of Recife, University of Montpellier, and University of Florida. Dr. Ribas is a renowned neurosurgeon and academic in Brazil with a special interest in brain tumors, central core of the brain, neuroanatomy, and awake surgery for functional brain areas. He is currently working as a neurosurgeon at Albert Einstein Israelite Hospital and University of Sao Paulo, Brazil. Apart from these, he is also a member of Brazilian Society of Neurosurgery and loves to teach neurosurgery to all aspiring neurosurgeons with many international lectures and courses. Thank you for joining us today, Dr. Abbas. The floor is all yours.
Thank you, Dr. Amir. It's a pleasure to be here. I always also want to thank Dr. Anam and Dr. Ashan for inviting me to organize this course and, of course, give this lecture. I did a long fellowship with Professor Albert Rotten in Florida in 2012 and 2013. And my main subject of research was a central core. So this lecture, this research, is a product of this fellowship that I did with Professor Rotten, and it's a pleasure to show to you part of these dissections. So this is a lateral view of the brain. And at the center of the lateral surface of the brain, we'll find the Sylvian fissure. The Sylvian fissure divides what is superiorly. We can find the frontal lobe and the parietal lobe. From what's inferiorly, we can find the temporal lobe. Deep inside the Sylvian fissure, we'll find the insular cortex. The insular cortex is seen as a separate lobe of the brain, since it's separated from the rest of the brain by the circular circles called the also that can be subdivided into the insular limiting sulci. We have one anterior, another superior, and another inferior limiting sulci of the insula that separates the insula from the rest of the brain. It's interesting that the insula is the lateral aspect of a very different place of the brain. The architecture of the brain is usually very uniform. It's made by gray matter on its surface and white matter on its inside, but not this block, not this particular region of the brain, that the insula is the most lateral part. This block, this part of the brain, we like to call the central core of the brain, because it's positioned at the middle, at the center of each cerebral hemisphere. This part of the brain is made by collections of gray matter that seems to be encapsulated by white matter. And if we take this axial cut that we find in all anatomy books, we can find that this gray matter and white matter appear to be organized into layers that alternate themselves. So if we come from lateral to medial, we find an alternating sequence of layers of gray matter and then white matter, gray matter and white matter. And we can name all these layers on this axial cut. So this is a more traditional view of this part. If we come from lateral to medial, we can name all these structures. So the first layer that we see more laterally is the insular cortex, that's gray matter. Then directly underneath, we have the extreme capsule. The extreme capsule is made by short association fibers. They are connecting the insular gyri between themselves, but are also continuing underneath the insular limiting sulci towards the opercula. Underneath the extreme capsule, we have the claustrum. The claustrum is a very thin sheet of gray matter whose function is not well understood, but some people give the ability of to be conscious to be related to the claustrum. Then underneath the claustrum, we have the external capsule. The external capsule is called external because it's lateral to the lentiform nucleus. So regarding the lentiform nucleus, we have an external and another internal capsule, okay, lateral and medial. So the external capsule is positioned laterally to the lentiform nucleus. Then we have the lentiform nucleus. The lentiform nucleus is made by two nuclei. We have a large nuclei called the putamen, is more lateral, and then we have the globus pallidus that is positioned on this angle here, the globus pallidus. Medial to the lentiform nucleus, we have the internal capsule. The internal capsule is subdivided into 5 segments. We have one anterior limb, then a genu, a posterior limb, and then we have a retrolenticular segment and a sublenticular segment, positioned posterior and inferior to the lentiform nucleus. Medial to the anterior limb, we will have the caudate nucleus. Not all the caudate nucleus, just the head of the caudate nucleus, because the caudate nucleus is a C-shaped structure that is wrapping around the thalamus. So at this axial cut, we just see the head of the caudate nucleus, but imagine this nucleus continuing embracing the thalamus posteriorly. Then medial to the anterior, to the posterior limb, we have the thalamus. The thalamus is the main structures of the diencephalon. So at this place that we call the central core, we are putting together structures that have very different functions and have very different origins, embryological origins. So some anatomists don't like to put these structures all together under the same name, but architecturally it seems reasonable for us to group all these structures because they are really close together and they form a very different morphology than the rest of the brain. But we are putting together very different structures. These capsules inside the central core, they are not just inside the central core, they continue outside the central core because they are white matter fibers that are connecting the central core to the rest of the brain. So at this dissection, I preserved the central core on this hemisphere here and removed most of the cerebral lobes to show that the central core is at the center of each cerebral hemisphere. And from the central core, these capsules continue towards the other cerebral lobes. And we can arrange, we can disposition these cerebral lobes in relation to the central core. So we have the central core at the middle, at the center, and then we have the frontal lobe anteriorly, parietal lobe superiorly, occipital lobe posteriorly, and temporal lobe inferiorly. That's 4 cerebral lobes. Then we have the 5th cerebral lobe, that's the insular cortex. We have it's the lateral aspect of the central core. And the 6th cerebral lobe, that's the limbic lobe, it makes 2 C's around these structures, particularly the thalamus. I'm going to show this later. The lateral ventricle also makes a C-shaped structure around the thalamus. And in position to the thalamus, it's subdivided into its extensions or into its horns. We have one anterior horn, anterior to the thalamus. Superior to the thalamus, we have the body. Posterior to the thalamus, we have the atrium. Inferior to the thalamus, we have the inferior horn. So it's these compartments are subdivided in relation to the thalamus. The occipital horn or posterior horn is just a continuation more posterior to the atrium. Inside the atrium, of course, we have the glomus of the choroid plexus, that's this membrane here. So we like this idea of putting the central core at the center of each cerebral hemisphere, and according to the central core, we can disposition the other cerebral lobes. So frontal lobe anteriorly, parietal lobe superiorly, occipital lobe inferiorly, temporal lobe inferiorly. And then at its lateral aspect, the insular lobe, and making 2 C's around these structures, the limbic lobe. As I mentioned, these white matter fibers that inside the central core are called capsule, they continue themselves toward the other cerebral lobes. So we can imagine these white matter fibers as arising, just like the rays of the sun arising from this center. At this cut, I made a deep cut to the insular limiting sulci, and we reach the lateral ventricle of the brain. This is a very unusual cut. We are detaching the central core from the rest of the brain, but it's actually it's related to neurosurgical practice. So we have a very particular neurosurgery that we want to disconnect part of the brain, one cerebral hemisphere from the other cerebral hemisphere. For example, in Rasmussen disease. Rasmussen disease is a disease usually on children that one cerebral hemisphere originates a lot of seizures, and for the patient to develop, we need to disconnect this hemisphere from the rest of the brain. So we have two options. We can do hemispherectomy, where the neurosurgeon will remove most of the cerebral hemisphere, or we have an hemispherotomy, where the neurosurgeon will make a cut that will functionally disconnect the cerebral hemisphere from the rest of the brain. And one of these cuts that the neurosurgeon will do in the hemispherotomy is this circular cut around the insula to disconnect the central core from the rest of the brain. So this cut is exactly this. It's a cut deep to the insular limiting sulci. The neurosurgeon will reach the lateral ventricle of the brain and disconnect most of the brain from the central core. And this cut, he is cutting the continuation of these capsules that inside the central core are called capsules, white matter capsules, but in fact they are continuing outside. At this dissection here, I want to show how the limbic lobe describes two C's around the thalamus. The thalamus is the main structure of the central core. So with the brain a little bit bent like this, we can see a C here. It's called the outer C or the cortical C of the limbic lobe. So we have the septal region, then we have the cingulate gyrus. The cingulate gyrus continues posteriorly with the isthmus of the cingulate gyrus, and then more inferiorly with the parahippocampal gyrus. This is a C, okay? This C is the outer C or the cortical C of the limbic lobe, okay? So this describes the C, and the center of this is the thalamus. Inside the parahippocampal gyrus, we'll have the amygdala anteriorly, then the hippocampus at the middle, and from the hippocampus, the fornix originates itself and finish at the mammillary body. This is the inner C or the subcortical C of the limbic lobe. And this C also describes a C around the thalamus. So it's called limbic because it's around, it's on the margin of the thalamus. And the limbic lobe so describes these two C's around the central core. At these dissections, we have a superior view of the central core. So the central core, it's here. The lateral aspect is the limbic, is the insular cortex. Then we have the middle of the central core, and the most medial structures is the thalamus. So this bulging ovoid structure here is the thalamus. And with my instruments, I am enlarging the choroidal fissure. The choroidal fissure is already a natural cleft that is separating the thalamus from the fornix. And with my instruments here, I am displacing the fornix and enlarging the choroidal fissure to show that the fornix, that is a limbic structure, is not actually connected to the thalamus. It's just mounted, it's just over the thalamus, but it's not connected to the thalamus. And as neurosurgeons, we need to understand the choroidal fissures as surgical routes, right? So if we open the choroidal fissure superiorly, for example, we'll reach the roof of the third ventricle. If we open the choroidal fissure posteriorly, we'll reach the quadrigem cistern here with the pineal gland inside. If we open the choroidal fissure inferiorly, we'll reach the ambient cistern, just lateral to the midbrain, to the mesencephalon. So with these three dissections, I want to show how the choroidal fissure can be enlarged and how the limbic structures can be just separated, but just displaced from the central core, because they are already naturally separated by the choroidal fissure. So with my instrument here, I have the hippocampus, okay, and the hippocampus continue posteriorly with the fornix. The hippocampus can be easily separated from the thalamus just by enlarging the choroidal fissure, but not the amygdala. The amygdala is found anterior to the hippocampus, and the amygdala does not have a natural division with the central core. Actually, the amygdala continues itself with the globus pallidus, just like the number 8 that have two circles, one over the other. The superior circle of the number 8 will be the globus pallidus. The inferior circle of the number 8 will be the amygdala. And the question of the neurosurgeon is how to separate these two structures. We are going to see this later. So we have these two C's. We have the outer C of the limbic lobe, just as I mentioned. Septal region, continue with the cingulate gyrus, continue with the isthmus of the cingulate gyrus, and then with the parahippocampal gyrus. This is the outer C, or the cortical C of the limbic lobe. If we take this same structure here and flip the other way around, we can see that inside the cingulate gyrus, we have the cingulum. The cingulum is a set of white matter fibers inside the cingulate gyrus that continues itself inside the parahippocampal gyrus also. And then inside the parahippocampal gyrus, we have anteriorly the amygdala and the fornix posteriorly. And the fornix continues itself, the hippocampus. And the hippocampus continues itself with the fornix. The fornix starts as a very fine structure called the fimbria. Then it develops into very flat structures, just like a tape posteriorly, that's called the crura, and then the body and the columns of the fornix. And anteriorly, the fornix splits itself just like a fork. One anterior part, it's called pre-commissural, and a posterior part called post-commissural. It's according to the anterior commissure that's positioned on the middle of this fork. The anterior commissure would be here. So we can also see that the amygdala is also already separated from the head of the hippocampus. In MRIs, in radiology, we can see these recesses here because CSF gets inside this space here. It's called the uncal recess. So the amygdala and the hippocampus are already anatomically separated. It's easy to see this in surgery as well. And we can see the hippocampus and its fibers arising and forming the fornix. And you see this is a C. Why this is a C? Because it's wrapping around the thalamus. The thalamus would be inside this C, resting on its surface, on this surface here. This surface here is the subiculum. Subiculum is the flat surface of the superior aspect of the parahippocampal gyrus, where the thalamus is resting itself. Okay, so it's called the subiculum. This is a superior view of the hippocampus to see this very particular shape of the hippocampus. The hippocampus has this shape that resembles the foot of a cat, the foot of a lion. The old anatomist called this the pes hippocampi, remembering that this shape resembles the foot of a lion. Okay, and then we have from the surface of the hippocampus emerging fibers that will get together and form the fornix. And the thalamus would be on this space here, laying on this surface here called the subiculum. If we see this space between the subiculum inferiorly and the fornix superiorly, we can see some vertically dispositioned gyri. These are called the dentate gyri, and they are also part of the limbic system. This is another dissection where I first open the sylvian fissure, expose the insular cortex, and made the deep cut deep to the insular limiting sulci, reaching the lateral ventricle of the brain. Here is nice. It's not very traditional dissection, but we can see here the ICA, internal carotid artery, then ACA and MCA, middle cerebral artery. M1 is the first segment. Then it bends itself at the limb insula, becomes M2. So M1 and M2 is related to the central core. Then already M3 here is at the opercula, right? And so it's outside the central core. So M1 and M2 is related to the central core, whereas M3 and M4 is related to the other cerebral lobes. But what I want to show at this dissection here is how the central core can be mostly detached from the rest of the brain by this deep cut that will reach the lateral ventricle of the brain. If we go even more medially and open the choroidal fissure, we will also separate the limbic lobe from the central core. So here I am enlarging the choroidal fissure and displacing, just detaching the hippocampus from the central core. Anterior to the hippocampus, we have the amygdala. And as I mentioned, the amygdala continues itself with the globus pallidus. How will the neurosurgeon separate the amygdala from the central core? It's also a very important neurosurgical question because, for example, temporal mesial sclerosis, where the patient develops seizures, the neurosurgeon want to get inside the temporal lobe and resect these temporal mesial structures, right? To the patient stop having seizures. And the neurosurgeon will get inside the temporal horn, see the choroidal fissure. What is lateral to the choroidal fissure, he can resect. That's the he can remove. That's the hippocampus. And anteriorly, we have the amygdala. But there is not a clear cut. There is not a natural division between the amygdala and the globus pallidus. How will the neurosurgeon make this cut? So I work with Professor Wen, who is going to teach us in another lecture. And Dr. Wen likes to use this point here. This is the inferior choroidal point. This is the point where the anterior choroidal artery gets inside the temporal horn of the lateral ventricle. Okay, inferior choroidal point. This is also the most inferior point of the choroidal fissure. That's why it's called the inferior choroidal point. So he looks for this point. And he looks for the ICA bifurcation. So he goes out and he sees the ICA internal carotid artery, and he sees its bifurcation, its top, and he will connect these 2 points and make a cut just parallel to this imaginary line connecting these 2 points. If we make this cut will be just lateral to the anterior choroidal artery, okay? So this is the anterior choroidal artery that arises itself from the ICA and gets inside the inferior choroidal point. If we make a cut following these 2 points, so ICA bifurcation and inferior choroidal point, we'll just be following the trajectory of the anterior choroidal artery, and we'll separate the number 8, okay? The superior circle will still be inside the central core, that's the globus pallidus. The inferior circle, that's the amygdala, will be removed with the other temporal mesial structures. So this is a way of doing this. Of course, there are other ways of doing this. Some other neurosurgeons will look for this structure here. This structure here is arising from the optic chiasm and going towards the lateral geniculate body. So this is the optic tract. So other people will look for the optic tract, it's okay, and make this cut just lateral to the optic tract. It's another way of doing this. With this is an anterior view of both central cores, and what I want to show is how the brainstem continues itself superiorly with the 2 central cores, one on the center of each cerebral hemisphere. I like to say that it resembles a dragon that has 2 heads. So it has the same body of the dragon, but superiorly it has 2 heads, one over each cerebral peduncle. So the mesencephalon has 2 cerebral peduncles, right? One on each side. And each cerebral peduncle continues superiorly with 1 central core. And in relation to the central core, we can disposition the other cerebral lobes. So anterior, we have the frontal lobe. Superiorly, we have the parietal lobe. Posteriorly, we have the occipital lobe. Inferiorly, we have the temporal lobe. On its surface, we have the insular lobe, and the limbic lobe will make two C's around it. So we have this dragon with two heads and then around all the other cerebral lobes. Inferiorly, we don't have a natural separation between the central core and the mesencephalon. So particularly the diencephalon, that's the thalamus, is already inside the central core, and the mesencephalon is inside the brainstem. There is not a natural subdivision, but most people will see the optic tract as the division of what's superiorly, that's the thalamus, from what's inferiorly, that's the diencephalon on mesencephalon. Now let's see white matter dissection. This is the first step of the white matter dissection. So we first freeze the brain, this, and then defreeze the brain later. This preparation makes the gray matter very friable, very easy to be removed. So the first step, we remove all the gray matter. This is called decortication, removal of gray matter. And what we can see is the first white matter layer of fibers, right, underneath the cortex. So this is the short association fibers. Then are putting together the gyri that are just near themselves. So this makes this form of a U, and they can be called U fibers. Okay, and they are under all cerebral surface. If we progress more deeply our dissection, we begin to see more long fibers. These long fibers will connect more far away regions. So we have these interlobar fibers that are connecting lobes between themselves. And we have this very big set of fibers that is called the superior longitudinal fascicle. The superior longitudinal fascicle is a concept that will put inside this concept all these fibers that are connecting frontal lobe to parietal lobe to posterior temporal region and occipital region as well. And we can see that the SLF, the superior longitudinal fascicle, it's outside the central core. It's called the perisylvian network. So it's connecting frontal, parietal, temporal, and occipital lobes, but it's outside the central core. Inside the SLF, inside the superior longitudinal fascicle, we have the arcade fascicle that has a very important role in semantic in language, right? So it's connecting the Broca region, the expression of language, to the Wernicke region on the dominant side. But what I want to show with this dissection is that the SLF is outside the central core because it's a perisylvian network. It's not inside the central core. The surface of the insula is divided by insular central circles into an anterior compartment made by short insular gyri that will converge into an apex, and a posterior compartment with long insular gyri that will not meet the apex. So we can see the dissection here, the short insular gyri getting to the apex, whereas the long insular gyri will not meet the apex, and between the anterior and posterior compartment, we have the central circles of the insula. These structures are finishing themselves anteriorly into the Lyman insula. The Lyman insula is this space here when M1 bends itself and becomes the M2 over the surface of the insula. If we decorticate the surface of the insula, we'll find the extreme capsule. The extreme capsule is the first subcortical layer, is the white matter layer that's directly underneath the insular cortex. So it's short association fibers putting together the insular gyri between themselves, but also continue underneath the insular limiting sulci towards the operculum. If we continue more deeply, we begin to find the claustrum. The claustrum is a very thin sheet of gray matter that's more organized dorsally and less organized ventrally, but it's all the claustrum. And from the claustrum arises fibers that are reciprocally connected to the cortex. So they come from the claustrum to the cortex and from the cortex to the claustrum. So these are called claustrocortical fibers or claustrofugal fibers because they are getting away from the claustrum, but they are actually reciprocally, they make this loop from the claustrum to the cortex, from the cortex to the claustrum. Anterior to the claustrocortical fibers, we see two sets of fibers. We see the IFOF anteriorly. The IFOF is the acronym for the inferior fronto-occipital fascicle. The inferior fronto-occipital fascicle connects the frontal regions to posterior temporal regions and occipital regions, but it's not a perisylvian network, just like the arcade fascicle that I showed. It's actually inside the central core. So while the arcade fascicle it's dorsally, the IFOF is ventrally. This is important because some people are regarding the IFOF related to the language as well, and it's also connecting the Broca region to the Wernicke region as well. But this trajectory is more ventrally and inside the central core. Some surgeries with awake patients where the IFOF is stimulated electrically, the patient develops semantic paraphasia. So it's a new insight into the concept of language and how language works. So some people are now bringing this idea that the IFOF should be included in our model of how language works in our brain. But from the anatomical point of view, the IFOF connects frontal to temporal posterior regions and occipital regions, and it's passing just anterior to the claustrocortical fibers. Anterior to the IFOF, we have the uncinate fascicle. The uncinate fascicle connects the frontal orbital region to the temporal pole. Okay, so it's the most anterior of these fibers. And we can see these fibers make a sequential, a sequence of fibers at the same depth. So anterior, we have the uncinate fascicle. At the middle, we have the IFOF. And posterior, we have the claustrocortical fibers. All these fibers are at the same depth. And we can see them lateral and medial to the claustrum. If they are lateral and medial to the claustrum, these three fibers can be seen as contributing to the extreme and to the external capsule. So I know it's a little bit confusing, but these capsule names are very old names, and the old anatomists didn't know this position, but now we know that these fibers are lateral and medial to the claustrum, so we can see them as contributing to both capsules. Okay. If we remove the claustrum, we see the putamen. Since this brain has been frozen, the putamen gets very dark, and that's why here the core of the putamen is very dark. Of course, in surgery it's not so dark, okay, but it has been frozen. Anterior to the claustrocortical fibers, we have the IFOF and uncinate fascicle. If we remove the IFOF, we see fibers that are coming from the other hemisphere. If fibers are connecting two hemispheres, they are called commissural fibers. These are the most lateral extension of the anterior commissure. The anterior commissure at the midline, the fibers are very condensed, are very dense, and they are packed together in the anterior commissure. But laterally, it opens itself and connects both temporal lobes. So the anterior commissure, some people gives the appearance of the part of the bike anteriorly that you use to drive a bicycle or a motor bicycle that connects. So at the middle is very dense, but laterally it connects the two temporal lobes. If we remove the putamen here, we see the globus pallidus. So the globus pallidus is medial to the putamen, and we can see how the anterior commissure is passing into a channel, into a canal, a trajectory just at the ventral pole of the globus pallidus. This channel is called the channel of Gratiolet, these old anatomists that describe this region. So there is not synapses here, it's just a channel where the anterior commissure fibers are just going through and getting to the temporal lobe. Okay, if we remove the globus pallidus, now we see what is medial to the lentiform nucleus. This is the internal capsule. The internal capsule is mostly formed by projection fibers. And since most projection fibers need to get inside the cerebral peduncle, that's a small region, they have this this radial disposition, because from all the cortex, these fibers need to converge and get inside the cerebral peduncle. And that's why it has this radial disposition, okay? A lot of fibers from all the cerebral lobes have to project to this small region at the mesencephalon, the cerebral peduncle, and so it has this radial disposition. We have one anterior limb, a genu, a posterior limb, and then a retrolenticular portion and a sublenticular portion, because here was the lentiform nucleus. Now bring attention to this region here. This gray matter that I left here belonged to the putamen. And I left this gray matter here because you're going to see that medial to this gray matter, we don't have internal capsule fibers. Okay, so internal capsule fibers are just superior and posterior to the anterior commissure. They need to go superior to the anterior commissure. What makes an absence, a lack of internal capsule fibers anterior and inferior to the anterior commissure. So the gray matter that belongs to the putamen laterally will merge with the gray matter that belongs to the head of the caudate nucleus medially, because there is no internal capsule here and medial to this gray matter here. And the gray matter of the putamen joining the gray matter of the caudate nucleus makes this another nucleus called the accumbens. Okay, so the accumbens is actually the gray matter of the putamen together with the gray matter of the caudate nucleus, because we don't see internal capsule here. So, okay, with this mark here, we can see this trajectory here, because we don't see internal capsule fibers at this region here, okay? And so develops the accumbens and the anterior commissure here. Now, as I mentioned, inside the central core, the white matter fibers are called capsules, but they are not just inside the central core. They continue outside the central core. The projection fibers inside the central core is called internal capsule, but outside the central core is called the corona radiata. These two names for the same structure. The same fibers continue outside the central core, but different names has been given. So inside the central core, we call internal capsule. Outside the central core, we call corona radiata. Some fibers of the internal capsule will go to the calcarine fissure. The calcarine fissure is the primary visual area, right? So they're also called geniculocalcarine fibers or optic radiation. They carry visual information. And some of these fibers develop first a trajectory inside the temporal lobe before going towards the occipital lobe and finishing in the calcarine fissure. This is called the Meyer's loop. The Meyer's loop is part of the optical radiation fibers that have a course inside the temporal lobe, make this very elegant loop inside the temporal lobe, and later finished at the calcarine fissure. And that's why surgeries addressed to the temporal lobe can indeed cause visual defects. If we go deep to the optical radiation, we see some vertically dispositioned fibers that are arising from the splenium of the corpus callosum. This is the tapetum of the corpus callosum. So the tapetum are callosal fibers, are commissural fibers. They are arising from the posterior aspect of the corpus callosum and are putting together both temporal lobes together. Okay, it's commissural fibers, and it's just medial to the optical radiation and just lateral to the atrium. Okay, since I have removed a lot of white matter, I see here the caudate nucleus from transparency. The caudate nucleus has a head, a body, and a tail. And the tail, some people will say it continues with the amygdala, but it's actually pointed to the amygdala. There are different structures, but it has this C shape. If I open the temporal horn, I see inside the temporal horn the hippocampus. Remember this very particular shape. This is the hippocampus. Anterior to the hippocampus, we don't see a natural subdivision. The amygdala continues itself with the globus pallidus. At this dissection here, I'm just enlarging the choroidal fissure. Now let's see the vascularization. The most typical vascularization of the brain is made by large arteries on the surface of the brain, and small branches arise from these large arteries and get inside the brain and supply the brain. This is the most typical pattern of vascularization of the brain that we see in all cerebral lobes. At the central core, we have this pattern of vascularization also at the insular cortex. So the insular cortex, it's supplied by these large arteries. This is M2 MCA, that branches arise and supply the insular cortex. But what about inside the central core? Inside the central core, we have a supply made by perforating arteries. These perforating arteries are arising from the circle of Willis, the polygon of Willis. Now, this is an inferior view of the polygon of Willis. Let's follow me here, please. Here is the ICA, internal carotid artery. If we follow the internal carotid artery, it divides itself into MCA laterally and ACA medially, right? If we follow the ACA, we can see that the ACA connects to the contralateral or ACA with the anterior communicating artery here. Anterior communicating artery, very small artery, but that communicates left to right ACAs. If we come posteriorly here, we see the basilar artery. The basilar artery on its top, on its superior aspect, divides itself into the two PCAs, in the two posterior cerebral arteries, one for each side. If we follow the PCA, we see there is an artery communicating the anterior system to the posterior system. This is the posterior communicating artery. We have two posterior communicating arteries, one on each side. What is easy to see is that from the polygon of Willis, a lot of small branches arise, and these branches are perforating the perforated substance. So we have two anterior perforated substances, one on each side, that are being perforated by the lenticulostriate arteries. Why it's called lenticulostriate arteries? Because it's supplying the anterior part of the central core. It's supplying the lentiform nucleus, the striatum, that's the putamen with the caudate nucleus, and the internal capsule. So lenticulostriate arteries. It's perforating both anterior perforated substance. Then posterior, we have one posterior perforated substance that is perforated by the posterior perforating arteries, also called the thalamoperforating arteries. The thalamoperforating arteries are arising from the basilar artery top and PCAs and are perforating the posterior perforated substance and will supply the posterior part of the central core, mainly the thalamus. So this is a lateral dissection where I removed the central core that was on our side, and we can see here the lenticulostriate arteries. The lenticulostriate arteries will supply the anterior part of the central core, whereas the thalamoperforating arteries, they are perforating the posterior perforated substance, will supply the thalamus, okay, also called thalamoperforating arteries. This is a lateral dissection. We can see the M2 over the insular cortex, and from the M2 small branches arise and will supply the insular cortex. Here we can see a white matter dissection of this part. We can see the uncinate fascicle here, IFOF here, putamen and globus pallidus. And what I want to show is that if we remove the IFOF and the uncinate fascicle, we can see the lenticulostriate arteries inside the central core. So these arteries first arise from MCA, perforate the anterior perforated substance, and then supply the putamen. It's very important for the neurosurgeon who is working inside the central core, because these arteries will not just supply the putamen. I'm going to show that these arteries, after supplying the putamen laterally, this artery will continue more medially and supplying the internal capsule and then the caudate nucleus. So if the neurosurgeon harms one of these arteries at the putamen, it might lead to ischemia of the internal capsule and the caudate nucleus as well, because the trajectory of these arteries is from lateral to medial. Okay, so it's an important anatomic information for the neurosurgeon who is dealing inside the central core. Here I am just displacing the putamen from the globus pallidus. We can see this, that some lenticulostriate arteries have a trajectory anterior to the anterior commissure, others are posteriorly. And here I am at the left, I have the putamen. And with this instrument here, I have the internal capsule. And here I am enlarging the space between the putamen and the internal capsule. And what I want to show is that the same arteries that first supply the putamen continue more medially to supply the internal capsule. Okay, and here I am removing the putamen and showing how this name, perforating arteries, is a very nice name, is a very appropriate name, because these arteries is really perforating these nuclei. Okay, I remove the putamen, I remove the globus pallidus, and now I am displacing the caudate nucleus from the internal capsule and seeing how the same arteries will continue from the internal capsule to the caudate nucleus. Okay, the same arteries will have a lateral to medial trajectory and will finish at the caudate nucleus. Here is an anterior view of the anterior perforated substance. The anterior perforated substance is perforated by the lenticulostriate arteries, and the trajectory is usually from lateral to medial. First supply the putamen that has been removed, then supply the internal capsule here, and then supply the caudate nucleus here. We have a very particular artery that's called the recurrent artery of Heubner. It's recurrent because it comes back. It arises from the ACA and then have a posterior course. It comes back posteriorly and perforates the anterior perforated substance and its most medial aspect. And this artery has a more straight course, a more direct course to the head of the caudate nucleus here. This is a lateral view where we can see the anterior commissure here. The anterior commissure has a lateral extension, but it also has a ventral extension that is putting together both olfactory regions. And here is a superior view of the anterior perforated substance. So usually we see the anterior perforated substance from underneath, right? But here we are seeing this superiorly. And we can see that just superior to the anterior perforated substance, we have some fibers. These fibers are just anterior to the cerebral peduncle. Most of these fibers are arising from the amygdala, and they are coming from the amygdala to the central core, passing anterior to the cerebral peduncle. These fibers, since they make a curve anterior to the cerebral peduncle, it's called ansa peduncularis. So why it's called ansa peduncularis? Because it's bending itself, it's making a curve anterior to the cerebral peduncle. So it's called ansa peduncularis. Actually, these fibers is a set of fibers. So we have this research that we did with our Chinese friends who could, with trotography, divide the ansa pedunculari into its components. So we have amygdalo-hypothalamic fibers, amygdalothalamic fibers, and amygdaloseptal fibers. Okay, so what we call together ansa peduncularis can be with trotography and fine dissection can be separated into separate fibers. So some of neuroanatomy can be studied with trotography as well. So this was the product of my research, is how to understand the trajectory of these fibers inside the central core, and we suggested a subdivision of the central core into quadrants, just to show for the neurosurgeon what fibers he will reach inside into quadrants. So each quadrant is related to a set of fibers. So we have 4 quadrants inside the central core, each quadrant related to a set of white matter fibers, and you can see our results at the Journal of Neurosurgery. We have this nice article there. So I want to thank the Pakistan Academy of Neurological Surgery for inviting me to give this lecture. Dr. Anam, of course, and Dr. Asham to putting all this together and supporting the lectures.